Hello, this presentation is on concussions. Our group consists of Kara, Miley, Drew, Delaney, and Sarah. The first topic we will discuss is the pathophysiology behind concussions. A concussion is considered a mild traumatic brain injury. It is due to head trauma and is fairly common in the sports world and with car accidents. Another possible mechanism in children and possibly older adults with balance deficits is accidental falls. Anytime the head receives an outside impact, the brain is susceptible to a concussion. When a traumatic brain injury occurs, the main neurological damage is an axonal injury. The compression impact of the brain causes a shearing force on the membranes of axons. This force causes the axon to stretch and ultimately tear. There is swelling at the site of the injured axon, which causes a breakdown of the axon distal to the injured site. When the axon becomes injured, there is also a disturbance in ion homeostasis. An unregulated efflux of potassium and influx of sodium in the axon leads to increased calcium concentrations, which leads to overactivity at the damaged nerve. Excessive calcium is never good for a nerve and can mediate further damage. These axonal injuries tend to primarily impact the basal ganglia, superior cerebellar peduncle, corpus callosum, midbrain, and cerebellum. Axonal injury likely contributes to the severity of symptoms endured after concussion, and damage is a major contributor to the development of post-concussion syndrome, a disorder we will discuss later in the presentation. When a concussion occurs, the capillaries in the brain tissue impacted can be damaged. When these capillaries rupture, the blood-brain barrier is broken and fluid leaks into the brain tissue. This fluid accumulates and creates edema that works in a feed-forward manner. Once swelling occurs, neurons start to become compressed and then send signals asking for more blood so they can get nutrients. When more blood comes, more blood leaks and swelling continues to increase. This edema can create the headache symptom that is common with concussions. The severity of axonal injury and microvasculopathy tends to give insight into the severity of a TBI. There is different neurophysiology involved with obtaining multiple concussions, usually presented as a condition known as chronic traumatic encephalopathy or CTE. For the sake of time, we won't be discussing this, but please reach out with questions if you are interested in this condition.
Now we are going to look at the clinical presentation of a concussion. A concussion is distinguished by a brief loss of consciousness, transitory post-traumatic amnesia, brief period of confusion, drowsiness, irritability, and light sensitivity. Initial signs and symptoms following a concussion vary based on where the brain is most impacted and the magnitude of the concussion. Frontal, temporal, and limbic areas are the areas typically damaged. Because of that, symptoms include poor judgment, decreased executive functions, attention disorders, poor divergent thinking, and poor emotional ability. Sensory may also be impaired. There may be problems with autonomic regulation if there is damage or compression to the brainstem or hypothalamus. Motor problems can include paresis, paralysis, spasticity, balance, speech, and eye movement disorders. Patients may present with some or all of these symptoms depending on the severity and area of brain damage. With post-concussion syndrome, there is a lingering set of disorders. Common symptoms include poor cognitive function, difficulty with concentration, irritability, sleep issues, headache, and mood disorder. These lingering symptoms can interact and cause worsening of the entire illness picture. Other signs and symptoms of post-concussion syndrome are listed on the slide. One exam commonly performed when there is a likelihood of a concussion is a pupillary reflex exam. For this exam, you shine a light into one of the patient's eyes. Here you are looking for both eyes to constrict. This exam must be done on both eyes. The reason we do this exam is because often the pupillary and consensual reflex may be absent in a patient with a concussion due to swelling that can place pressure on these midbrain components, and that will prevent the axons from communicating the info appropriately. Not everyone with a concussion will have a lack of pupillary consensual reflex, but a lot of people that do have a lack of reflex do have a concussion if we are testing specifically after the injury because there shouldn't be swelling there to prevent this pathway from taking place. Imaging can also be used to see where damage from the concussion has occurred in the brain. This form of imaging can pick up ions and proteins in the blood and CSF from axonal injury and use these biomarkers to create a picture of the extent of the injury. DTI looks at how water moves along the white matter, while MRI evaluates changes in blood flow. The final tool we want to discuss is called the Sport Concussion Assessment Tool, also known as SCAT. Both are commonly used methods to get a quick assessment of whether or not the patient may have a concussion through the analysis of symptoms they may be experiencing. Both images show the symptom checklist portion, but the SCAT as a whole also includes a physical sign scale. Glasgow Coma Scale, sideline assessment called the Maddox score, cognitive assessment, balance assessment, and coordination examination. This tool is typically used right after the injury occurs and can help the practitioner determine the severity of the concussion and whether or not the athlete can return to play immediately, and if not, how long the recovery period needs to be. A head injury can lead to several other conditions besides a concussion, one of those being a subdural hematoma. Head trauma can cause shearing of bridging veins crossing from the arachnoid into the dura. As the superficial veins cross into the dura mater, an injury that shears them can cause them to rupture and the blood to escape and form in the potential space. Blood then spreads out in the space between the arachnoid and the dura. In a subdural hematoma, since the blood pressure is coming from veins, the blood pressure is low. As the blood is trickling out, you see deficits over the course of a few days to even a few weeks. Ultimately, the deficits will be the same as a concussion because you have a compression of brain tissue. The difference is the time lag due to the difference of pressure within these blood vessels. If you are unsure and concerned your patient may have a subdural hematoma, imaging can be done to determine if this is the issue. A contusion is a bruise on the brain that can cause swelling and can also be seen with imaging. It is possible to have no symptoms at all with a contusion, besides minor pain or swelling on the area that the head was impacted.
Moving on to the pharmaceutical treatment of concussions. So, most patients suffering from a concussion recover quickly. Therefore, the use of pharmaceuticals is unnecessary when considering the pros and cons of each. However, if concussion recoveries are prolonged, medical therapy should be considered. There is no standard approach to the medical treatment of concussions because there has been no effective pharmacological treatment that has been shown to speed its recovery. Therefore, the use of pharmaceuticals revolve around treating the most common symptoms of concussion: sleep disturbance, somatic effects or headaches, and emotional and cognitive deficits. We will go over each of these symptoms and the drugs used to treat them individually in the next few slides. The first symptom to be discussed is sleep disturbance. Melatonin is commonly used to treat sleep disturbance. Melatonin is an endogenous hormone produced by the pineal gland. It is important for regulating circadian rhythm in sleep. Melatonin is generally safe, but when taken excessively, circadian rhythm can be disrupted and side effects may occur. These side effects include dizziness, irritability, daytime sleepiness, headache, and depression. Headache is the most common symptom following a concussion. Although NSAIDs are the most popular drug to treat headaches to the general public, they are discouraged due to their ability to promote rebound headaches and further complicate recovery. Amitriptyline is the most common pharmaceutical used to treat the somatic symptoms of concussion. Although amitriptyline is an antidepressant, it is ideal in treating the somatic symptoms of concussion because of its effectiveness in treating tension and migraine-type headaches, the two most common forms of post-traumatic headaches. Amitriptyline also has sedative effects which can further help those suffering from sleep disturbances. Amitriptyline works by blocking the reuptake of serotonin, therefore increasing the levels of serotonin in the brain. This slide lists all the side effects of amitriptyline. The most common emotional symptom of concussion is depression. This can be due to a patient's inability to participate in their normal daily lives, such as attending work, school, soccer practice, and so on. SSRIs, also known as selective serotonin reuptake inhibitors, are used to treat depression. Common SSRIs used in treating depression caused by traumatic brain injury are Prozac and Celexa. Similar to amitriptyline, SSRIs work by increasing the levels of serotonin in the brain by blocking its reuptake at the synapse. Side effects of SSRIs are similar to those of amitriptyline because they are both SSRI antidepressants. As Drew mentioned, cognitive symptoms of concussion include difficulties with memory, concentration, and slowed processing speed. Methylphenidate, a drug used to treat ADHD, attention hyperactivity disorder, has been shown to treat these deficits in patients with concussion. This drug works by blocking a dopamine transporter protein that reuptakes dopamine from the synapse, resulting in increased dopamine levels in the brain. The use of this drug should be examined due to its potential for lowering seizure thresholds. Other common side effects of this drug include stomach ache, which can lead to decreased appetite and weight loss, nervousness, which can include shaking and sweating, mood swings, fever, increased heart rate, and dizziness.
Next, we will discuss the role physical therapy plays in concussion treatment. During the acute phase, physical and cognitive rest until the symptoms subsides continues to be the most accepted management strategy for concussions. During this time, patients should be seeking medical attention and screening. Some of the common post-concussion tests include the post-concussion scale, acute concussion evaluation, and impact testing, which is used by high schools, colleges, and major leagues around the country to see pre- and post-concussion results. There's currently no clear or uniform guidance describing a physical therapy treatment approach for concussion-derived symptoms. Also, concussion patients usually don't see a physical therapist until later in their recovery phase. Return to activity is usually held off until a patient is seen as asymptomatic, but more current research is diving into how long this rest period should be and at what phase of recovery different physical activities may be reintroduced. In a recent study just published this month, the American Academy of Pediatrics updated its concussion recommendations to support that children and teens engaging in light activity and returning to school as they recover. The report, revised for the first time in 8 years, also advised against complete removal of electronic devices such as televisions, computers, and smartphones. These new changes to reintroducing physical activity during acute concussion treatments are becoming more and more accepted with continual research. Although most patients recover from a mild traumatic brain injury within 7 to 14 days, 10 to 30% of people will experience prolonged concussion symptoms. This can be described as post-concussion syndrome. As I mentioned before, there is no standardized treatment protocols to guide physical therapy interventions for this population. A study completed in 2015 found a number of treatments that proved successful for this patient population. At the time of the evaluation, several tests and screens were included. They were a cervical evaluation for range of motion and strength, aerobic activity assessment, oculomotor screening, and a postural control assessment. Listed on the screen are a number of treatment styles they use within their treatment sessions. For cardiovascular improvement, patients could choose to bike, walk, or use the elliptical, but they were expected to reach a level of 11 to 13 on the Borg REP scale. The goal was to increase cardiovascular endurance with minimum to no symptom exacerbation. Musculoskeletal treatment interventions included stretching, resistance exercises, postural re-education, and manual therapy. For postural control, balance and dual tasking was found appropriate to test both the physical and cognitive improvements. To test vestibular oculomotor, a gaze stability exercise was also included. All of these treatment styles were seen as appropriate post-concussion symptom care.
This article by Nicole Miranda addressed how the dizziness often caused by a concussion caused people to refrain from moving their head to avoid noxious trigger. This stabilization of the head increases cervical tension and triggers headaches. Over time, the person fixes the head on the body, which affects reflexive head reactions and the recruitment of vestibular spinal reflexes for the typical ankle, hip, and stepping strategies involved in balance. She also discussed how people often struggle to focus in class, tolerating complex environments such as a gymnasium, and tolerance for crowded places such as stores or lunchrooms. To help decrease the constant headache loop, modalities such as TENS, interferential current, and intermittent icing can help control pain from the cervical muscle spasms. Vestibular rehabilitation done by a PT can include using regular exposure to optokinetic stimulation to reduce visual motion hypersensitivity by creating visual disturbance. This is often done by having the patient look at black and white lines moving on a screen. If you're interested to see what this looks like, just YouTube optokinetics. Brief exposure and activities performed while subjected to the visual stimulation reduce the brain's hyperexcitability and sensitivity to visual motion provoked dizziness. Contraindicated treatment. When working with a patient post-concussion, it is important to not do any exercises, stretching, or any other tasks that might exacerbate the concussion syndromes. For example, when working on or assessing the cardiovascular system, you want to avoid excessive biking, walking, or any aerobic exercise that might bring upon symptoms. When working on the musculoskeletal system, exercises such as overstretching neck muscles, scapular retractions, and manual glides of C2 and first rib mobilizations are contraindicated when there is a positive finding for cervical instability. For postural control, you want to be careful if the patient presents with a heightened fall risk to avoid exercises that might cause the patient to fall. If a patient presents with a vestibular ocular motor symptoms beyond your knowledge or scope of practice, it is necessary to make a referral to a vestibular specialist. And these are our references.
Thanks for listening.